Thank you, Dr. Gazard. Our next keynote speaker is for Ocular Regenerative Medicine under the leadership of Dr. Alan Slomovic. I'd like to introduce to you Dr. Sophie Deng. Dr. Deng is a professor, the director of the Corneal Biology Lab, and co-director of the Center for Regenerative Medicine in Ophthalmology at the Stein Eye Institute at UCLA. She'll talk to us today about the current status on the diagnosis and treatment of limbal stem cell deficiency. Dr. Deng.
Thank you so much. Thank you for the invitation to present today. So we're talking about a limbal stem cell deficiency, LSCD. What is it? It is a disease due to a lack of functional corneal epithelial stem cells that reside in the limbal region. So often when we think about this disease, those are the eyes that come to your mind. The eyes are opaque, with persistent epithelial defect, symblephalon. But in fact, the disease consists of a spectrum of presentation based on the degree of the stem cell deficiency. As you see that in the upper panel, those eyes presented with sectoral, partial limbal stem cell deficiency. The dye, the fluorescein dye, stain the abnormal epithelial cells. Those are the conjunctival epithelial cells migrated into the cornea. In the bottom 3 panel, and you can see those eyes had a more severe stage. The left lower panel has the typical vortex pattern of the stippling staining and epithelial thinning. The staining is not epithelial defect, but epithelial thinning. And when the disease becomes more severe, and you can see that the corneal transplant does not survive, and the patient can present with persistent or recurrent epithelial defect. A few years ago, when you asked 5 corneal specialists in the room and how did they define, classify, diagnose, stage, and manage this disease, you might get 6 answers. So in order to reach a consensus on this disease, the International Limbal Stem Cell Deficiency Working Group was formed. Dr. Alan Slomovic and Dr. Claire Chan were the 2 key members that drive to the final consensus. So how do you make a diagnosis? First of all, get a good history. Secondly, do a good clinical exam using fluorescein and also the in vivo imaging later on to confirm the presence of abnormal cells or absence of the normal cells. And finally, the in-person cytology to detect goblet cells or cytokeratin keratin 13 or 7 or mucin 5, mucin 5AC1 would be the adjuvant diagnostic test. So when I take you through how to do a good exam, first of all, the bright light illumination itself is insufficient. So these eyes have a very clear cornea, but when you do the fluorescein staining, look at how abnormal the ocular surface is. So there's another case. This patient had a successful DSEC, but the patient still seeing only 100. Why? Look at the surface. It's very irregular due to the partial stem cell deficiency. The appropriate amount of fluorescein on the surface is critical. When it's too little, you cannot see because it doesn't stain. When it's too much, you still can't see because the staining pattern is overwhelmed by the excessive dye. For example, on the left, when there isn't enough fluorescein staining, you don't see any pathology. And the right panel, you see that the ocular surface was very irregular due to the stippling staining of the cornea. There's another case of when you put too much dye, you can see the dye, but you don't see the pathology. So when the dye is dissipated, you can see beautifully on the superior quadrant the pathology. Inducement OCT is very helpful in the initial screening of the patient because this patient developed epithelial thinning. On the left panel, the cornea is normal. You can see the epithelial map is normal. In the limbal region, I don't have a pointer here, you can see those hyporefractive layer of limbal epithelium. On the right panel, then you see the superiorly, there's thinning of the epithelium. in the superior limbus, the bottom OCT, there is absence of the hyporefractive layer, meaning that the limboepithelium is absent in that location. In vivo confocal microscopy also demonstrated very clearly that there is decrease of the normal number of the corneal epithelium in the middle panel. In the mild disease, you can see the cell already become larger. In the intermediate stage, you can see the cell become much larger and metaplastic. In the late stage, there's absence of such cells that resemble corneal epithelium. In the bottom panel, in the limbus, such a morphology also is observed. In addition, there's increased influx of inflammatory cells. So we decided to have to look at these biomarkers, basal cell density, epithelial thickness, subbasal nerve density, and cell morphology, and those can be used to stage the outcome of the limbo stem cell study. Transplant. This is a phase 1 clinical trial that we are ongoing. We use a xeno-free and fetal-free culture system to grow the culture, and then we use those in vivo imaging to determine the outcome. So this patient on the left panel is the baseline, 2200, and the surface very irregular. In 6 months and 12 months, the cornea become much more clear. In confocal microscopy, on the left side is the baseline pre-op, and 6 months, 12 months, you can see the morphology of the normal epithelium. In terms of OCT, epithelial thickness, on the top panels before surgery, there's absence of hyporefractive layer of epithelium. In the 6 months, 12 months, those layers be restored. In addition, I mentioned about molecular markers. Cytokeratin 13, 7, mucin 1, mucin 5AC also can be detected on the corneal surface to signify the presence of conjunctival epithelium, which is a hallmark of the disease. How about management? Before talking about management, we look at the staging. So this is really important to first determine the degree of deficiency. In stage 1, the central cornea is spared. Stage 2, the central cornea is affected. And stage 3, entire cornea is affected. How about the management of this disease? First of all, before even we talk about the transplant and the stem cells, we have to rehabilitate the ocular surface if the patient has comorbidities. The ocular surface, first of all, have to look into the eyelid abnormality or conjunctival abnormality. Those need to be reconstructed. And secondly, any inflammation on the ocular surface should be managed. And third, the tear film, the dry eyes, can be really detrimental to the stem cells. And fourth is optimize the ocular surface epithelium. So if any toxicity on the ocular surface, that should be removed. For example, preservative eye drops should be replaced by the preservative-free formulation. And finally, when the entire ocular surface is optimized, then we look into the surgical treatment of the disease. And once the ocular surface is reconstructed, if there's residual corneal stromal scars, then further surgery intervention could be considered to improve the visual outcome. So it's important that the first step is to maximize the ecosystem of the ocular surface and provide the best environment to engraftment to achieve a long-term survival of those transplanted limbo stem cells. And potentially, those management can enhance the survival of any residual stem cells in partial stem cell deficiency. So this is very, very busy slide. I want to take you through this algorithm that developed by the consensus group. The left side is for the unilateral and bilateral less severe disease. Stage 1 is stage 2A. Those patients, observation, there's no comorbidity, and first step is to do the medical treatment or contact lenses if there's comorbidity. And after that, if patients still have significant visual impairment, then consider removing those abnormal epithelium without amniotic membrane transplant. In more severe stage, and the management based on the laterality. In urinary disease, first of all, again, medical treatment and or with contact lenses, first to optimize circle surface, then our autologous limbal stem cell transplant is preferred over all other modality. In eyes with bilateral disease, then the allogeneic transplantation, keratoprosthesis, or ex vivo expanded or mucosal epithelium could be considered. So in conclusion, first of all, in order to make a correct diagnosis, a careful examination followed by confirmatory diagnostic test is recommended prior to surgical intervention if all possible. Medical management to optimize the ocular surface should be the first step. Successful restoration of the limbal stem function requires a comprehensive team approach. And fourth, the choice of treatment really needs to be tailored to the degrees of deficiency and the experience of the surgeons, as well as the availability of any treatment modalities. If there's not available in terms of Boston capable, then you might look into allogeneic transplantation. The most important thing is that efficacy of each treatment needs to be determined by randomized controlled clinical trial. And thank you very much for your attention.
Thank you, Dr. Deng. I'd like to now invite Dr. Clara Chen to present us the cornea keynote speakers.
Good morning. Our first cornea guest speaker will be Dr. Irit Bahar. She is the chief of the ophthalmology department at the Rabin Medical Center in Israel. She's a clinical professor at the Sackler Faculty of Medicine at the Tel Aviv University. And she'll be speaking on an update on the various corneal transplantation techniques.
Okay. I need the speaker here. Is it fine? Can they hear me? Can you bring me the microphone over here? I'm going. I'll just go here. The microphone is too far from me. I'm going to present here in the Mac. Okay. Can you just cut it here?
Sure. Please, Alan. Yes.
So while we're changing microphones, I just want to say it was an outstanding talk on limbal stem cell, but it really highlights the importance of the comprehensive ophthalmologist in making the early diagnosis and the early management of treating the ocular surface, things like, contact lens wear, meibomian gland disease can really aggravate limbal stem cell disease. And if you get it early, and with the comprehensive ophthalmologist, you can avoid getting into much more serious issues where they need stem cell transplantation.
Totally agree, because when we received referral from the outside ophthalmologist to participate in the phase 1 clinical trial, half the patients after optimization of ocular surface, they no longer meet the criteria because they're much better. So again, medical treatment is incredibly powerful or effective in reducing the damage, like continuous damage to the stem cells. So I think that this is the first step.
So good morning, everyone, and thank you for the warm hospitality. Actually, my real challenge today would be to review corneal transplantations technique in 10 minutes. So let's start quickly. I have no conflict of interest. So while full-thickness corneal transplant techniques have not changed much over the past century, lamellar corneal transplant technique have evolved rapidly. The different acronyms that accompany the various corneal transplant technique can easily become disorienting. So let's go through quickly. PKP, penetrating keratoplasty, stands for full-thickness corneal transplant. DALK, which is deep anterior lamellar keratoplasty. Posterior anterior lamellar keratoplasty will be discussed and will include DSEC and DMEC. And finally, we'll have several words about the K-Pro. These lectures aims to introduce the keratoplasty technique that are most commonly used today. So let's start with penetrating keratoplasty. When Edward Konrad Zirm performed the first successful full-thickness penetrating keratoplasty in a human in 1905, he became the first person to perform solid organ transplant. Ironically, he performed the surgery for one of the most challenging indications in ophthalmology, the bilateral alkali burn. These are the different indications for full-thickness transplant. Generally, we use it when a pathology like scar, trauma, infection involves all layers of the cornea. PKP was previously our state-of-the-art with almost 120 years of experience, and success rate varied between 50 to 90%, depends on the initial indication, but many problems persisted. The basic of this surgery is removing the diseased cornea and replacing it by a normal and transparent donor tissue. We use all kinds of trephines and punch to cut the cornea in a specific size and accurate manner. And I'll show you a short video. So we're starting by the corneal trephination. And then after cutting into the cornea, just placing the marker for the sutures, filling the AC with a viscoelastic substance, and now just removing the diseased cornea using special scissors like Castroviejo scissors, and then replacing it with the new donor tissue. And we have to put all stitches all the way around. There are different ways to put those stitches. And just skip to the end of the surgery. Its advantages include long experience with the procedure. It's relatively straightforward to perform. There's little intraoperative endothelial trauma and no potential for lamellar interface haze. However, the disadvantages are well known and include prolonged visual rehabilitation, usually more than a year, high astigmatism averaging 5 to 6 diopters, suture-related problems such as broken sutures and infectious keratitis, wound dehiscence, which can happen even years later, graft rejection and endothelial failure. And finally, we have this open sky moment, which is very risky and we prefer to avoid. Deep anterior lamellar keratoplasty is a partial thickness corneal transplant procedure that involves selective transplantation of the corneal stroma, leaving the native descemet membrane and endothelium in place. There are two main techniques for this operation: the manual dissection of the stroma, which removes layer by layer down to descemet, or big bubble technique, which personally I prefer. The indication for DALK include corneal ectasia, such as keratoconus in the absence of eye drops, corneal scars that are not full thickness, and corneal stromal dystrophies. So I'm going to show you a video of the big bubble technique. So a trephine of an appropriate diameter is used to make a partial thickness incision into the patient's cornea, followed by manual dissection of the anterior stroma. So we're just dissecting the anterior stroma and removing the anterior lamella. This is followed by pneumodissection by big bubble injection into the deep stroma, which separates the stroma from the descemet membrane and endothelium. Then the anterior lamella is excised. And now, corneas, and then comes the placement of graft prepared from a full-thickness sponge in which the donor endothelium and descemet membrane complex has been removed. And the intention is to preserve patient descemet membrane and endothelium. And similar to PK, the graft is secured with interrupted or running sutures, and these are then selectively removed postoperatively. This is the appearance post-DALC. It may look very similar to PKP at a slit lamp. And advantages include preservation of corneal endothelium, less rejection, early sutures removal, fast visual recovery, faster, and avoidance of the open sky stage. The disadvantage include a steep learning curve and the interface that sometimes can reduce visual outcome, especially when the lamellar dissection is done. Posterior lamellar keratoplasty involves replacing the posterior lamella of the cornea, namely descemet membrane and endothelium. I will mention today the DSEC and DMEC, which are the most commonly used nowadays. Indication involves all diseases that affect corneal endothelium, including PBK, Fuchs dystrophy, posterior polymorphous dystrophy, aphakic bullous keratopathy, eye syndrome, and failed PKP. The journey of PLK began with Dr. Meles, who around 1996 started to work on lamellar technique for posterior transplant, and Dr. Meles, together with Dr. Mark Terry and Gorovoy and Francis Price, improved and popularized those techniques. And this led to a rapid evolution of lamellar keratoplasty from PLK to DSEC and DMEC in the new era of posterior lamellar keratoplasty. Descemet stripping automated endothelial keratoplasty, DSEC, is the most popular modification of PLK, in which the patient descemet membrane can be easily peeled off using specially designed strippers. And we use a microkeratome to prepare the donor tissue. You see here the microkeratome, which will do a lamellar dissection and cut the cornea in a specific depth, usually at 350 or 400 microns depth in the cornea. And this leaves us with endothelium and a small amount of stroma in our donor lenticule. So this is a three-step procedure: microkeratome preparation of the donor, descemet membrane stripping, and then insertion and positioning of the donor. And this is a short video now showing a pediatric DSEC after failed DMEC. So you show me taking off the failed DMEC and just doing some desmetorexis and venting incision. This is a paracentesis, creating a corneal incision, and then loading the graft into the Macaluso glide. And then insertion of the graft, just pulling it through into the anterior chamber. After positioning the graft, we will fill the anterior chamber with air, so it will float the DSEC lenticule and adhere it to the recipient cornea. So this is it. This is the appearance one day post-DSEC, and this how it looks at 1 month, as opposed to this appearance here that you can get with PKP even a year after the transplant. DMEC is the next stage in the evolution of PKP. It was published by Gerrit Meles in 2006, and it took surgeons several years to adopt these techniques, mainly due to challenges associated with learning curve. Again, we have almost the same three-stage procedure, but stage 1 and 3 were modified because here we have just to peel the endothelium and descemet membrane, stain it, and just I'll show you in a movie, stain it and put it, just inject it through an injector into the anterior chamber, and then just tap on the cornea and open this cigar-shaped donor tissue. And again, after it's open in the flat anterior chamber, just use an air bubble, fill the anterior chamber with an air bubble, and adhere it to the recipient's cornea. Sorry. And so this is how it looks like. It can look like this just day after surgery, and this is amazing, really. It looks like the cornea becomes clear in no time, and it can hardly be notified that the patient had gone corneal transplantation. It's amazing. So the pros: no open sky, it is a refractive neutral surgery, no wound-related problem, no suture-related problem, fast recovery, less rejection, really all the benefits, better visual acuity. And the disadvantages are the steep learning curve. There is probably more endothelial cell loss, and we started to face complications like disc dislocation or detachment of the graft. Keratoprosthesis, the transplantation of an artificial cornea, was first performed in Italy by Benedetto Strampelli at 1960s. Why K-Pro? Because patients requiring a repeat corneal transplantation highlighted the need for an alternative to corneal allograft treatment, as graft survival rates drop with each additional procedure. Other indications include chemical burn, Stevens-Johnson, OCP, who are altogether poor candidates for human donor corneal transplant. Boston K-Pro is the most popular K-Pro. It was approved by the FDA back in 1992. The device consists of a clear plastic optic and a prosthetic plate that are sandwiched around the donor allograft for a patient's own corneal tissue. The device is then sutured onto the recipient's cornea. And this is the appearance of type 1 Boston K-Pro in situ. Osteodontokeratoprosthesis is another huge surgery of K-Pro that is done only in 9 centers worldwide. Historically, it preceded the Boston K-Pro by several decades. And this surgery uses the jaw and the teeth of a patient in order to connect the artificial cornea to the eye of the blind patient. It is a heroic procedure that requires lots of resources and multidisciplinary approach, and we're very proud to be a site of this significant blind-saving procedure in Israel and actually in the whole Middle East. I have to emphasize that because these are very complicated surgery, they are reserved only for a very selective patient who cannot get a human cadaver transplant nor Boston K-Pro. So this is how the artificial cornea is prepared. And this is Dr. Livni and Dr. Iftach Yassur from my department that are leading those surgeries. And this is this blind patient looking at himself in the mirror for the first time. This is a very exciting photo. And we have now 3 years of follow-up, and this is still 2020. The Cornit Vision is an Israeli company with a vision to develop artificial cornea that will hopefully replace biological tissue and save the waiting time for human donor tissue. Their product is innovative and is totally different from the competitors, but this is under phase 1 clinical trial, and I presented it earlier in the meeting, so I will not elaborate on this one. So I will conclude this talk by saying just that we are all very lucky to practice medicine in the era where technology enables fulfilling great ideas that were already mentioned by the ancestors of corneal surgery more than half a century ago. Thank you very much.
Thank you, Dr. Bahar. Our next speaker is Dr. Bala Ambati. After completing his medical degree at 17 years old, he's been in practice in ophthalmology the last 20 years already. He's a professor at the University of Oregon and the president of the Pacific Clear Vision Institute. He's a clinician scientist whose startup is working on everything from treating keratoconus with eye drops to myopia with eye drops to cataract with eye drops, and pretty much trying to stamp out any ocular disease with eye drops. So he's speaking today on an update on neurotrophic keratopathy management. Thank you.
Good morning. Good morning. Clara, thank you for that kind introduction. And we're not developing any eye drops against cataract, but we are doing some of the other things. So today we're going to talk about some recent advances in neurotrophic keratopathy and persistent epithelial defect. I have no financial disclosures. So the traditional approaches for these conditions that really are the bane of every cornea practice because they're difficult to treat and they linger and they lead to other complications. Traditionally, we have amniotic membranes, bandage contact lenses, scleral contact lenses, lots of vitamin C, doxycycline, topical medroxyprogesterone, and trying to treat any underlying causes. But treatment remains unsatisfying. So in the last few years, there's been some things that I think are worth discussing and disseminating. Nerve growth factor was recently approved in the US. Insulin eye drops and amniotic fluid eye drops are now commercially available, generally by compounding pharmacies. And there's a surgical technique called neurootization that was developed at Wills Eye Institute and Wilmer. So let's talk about each of these in turn. So topical insulin is a promoter of epithelial growth. And so this is very neat because we have very few things that actually serve as a growth factor for epithelial cells. Very easy to prepare 10 units of regular insulin in a brand new artificial tear bottle twice a day for about 4 to 5 weeks. It's important to label the bottle correctly so that their other general doctors aren't confused about why is this patient getting insulin. So the largest trial so far came out of Spain, where they compared head-to-head topical insulin versus autologous serum. This was a retrospective series, and 61 patients got insulin and 23 got autologous serum. So some key findings of this. 84% of the insulin patients reepithelialized with closure of the epithelial defect, and only 48% of the autologous serum patients did so. The mean time to reepithelialization and closure of the defect in the patients who completed epithelial closure was shorter in the insulin-treated patients, and those insulin-treated patients, as you would expect, needed less surgeries, tarsorrhaphies, amniotic membranes, whatever, what have you. Infectious defects also had a greater epithelialization rate with insulin than with autologous serum, and recurrence of the epithelial defect was less with the insulin-treated patients. So pretty much across the board, insulin was superior to autologous serum and much easier to prepare. It's also been used for refractory neurotrophic ulcers. This was a chart review of 6 patients, and the defect resolved within 1 to 3.5 weeks in all of these 6 patients. These are some representative images from that paper, and you can see the left column is pre-treatment, the right column is post-treatment, and different causes, orbital teratoma, herpes zoster, keratitis, and cranial nerve injury, dramatic improvement in the epithelial defect as well as the corneal appearance. So I think this is a very exciting, cheap, new alternative for treatment of a persistent epithelial defect. Oxervate is the only FDA-approved drug for neurotrophic keratopathy. It is a form of recombinant nerve growth factor, and so this derived from Nobel Prize-winning research by Rita Levi-Montalcini. There were 2 large clinical trials in Europe with successful healing of neurotrophic keratopathy epithelial defects. The challenge with this is it's extremely expensive. In the US, a 6-week course can easily be $2,500 or $3,000. So in the absence of insurance coverage, this becomes cost prohibitive for most patients with these problems. Just in this last 8 months, we've now had access to a new eye drop called Regenerize, which is a formulation of eye drops derived from amniotic fluid and placental tissue. It's an acellular solution. It has a lot of factors inside it. It's not a single substance eye drop by any means. Some of the important mechanisms through which it works are inhibition of interleukin 1 receptor. So it has a blocker of that. So that cytokine is inflammatory. So by blocking interleukin 1 receptor, it blocks the activity of interleukin 1 beta and reduces inflammation. It also has something called FABP, which is reduced in patients with Sjogren's and dry eye disease. By adding FABP, that seems to improve water transport and tear stability. And in addition to those 2 key molecules, the Regenerize seems to inhibit TNF-alpha and other inflammatory cytokines. So clinically, what's been published so far is that it's been useful for the treatment of dry eye with a period of 1-year follow-up. There were no adverse events and a significant reduction of speed scores within 3 months of treatment. I have been using Regenerize for patients with refractory dry eye, with mild corneal haze from a variety of causes, and it seems to be a useful adjunct in the management of these conditions. The last topic is something I do not have experience with, but I think it's worth reporting and discussing. So a couple of centers, Wills and Wilmer, I believe, have done neurotization for patients with neurotrophic keratopathy. So this involves a surgical translocation of donor nerves to reinnervate the cornea. You can use this with direct neurotization from adjoining nerve distributions, the supraorbital or the infraorbital or supratrochlear nerves. The published reports are quite remarkable, taking pretty advanced neurotrophic keratopathy disease, reinnervating the cornea, and that results in dramatic improvement. There's also a newer procedure of indirect nerve transfer where you use tissue from the sural nerve or antebrachial nerve or auricular nerve, and that's also had good results. Both direct versus indirect seem to restore corneal sensation about 80% and reduce or resolve numbness within 3 to 6 months. They have different complications related to where you're harvesting the nerves from, but they both seem to be good surgical approaches. I would classify them in this last-ditch surgical alternatives for patients who have failed all medical options. So thank you very much.
Thank you, Dr. Ambati. We have a short period for questions. We are running a bit late. Are there any questions for the cornea or ocular regenerative medicine keynote speakers?
Maybe for the audience, I'll ask Dr. Bahar, when you choose between, say a cataract surgeon sees a patient with an endothelial disease and they themselves are not going to be performing the cornea transplant, how do they prepare the patient in terms of from a phakic status or pseudophakic status for the cornea specialist to, in the future, potentially do the endothelial graft?
So you mean a Fuchs dystrophy that has cataract?
Right, exactly.
So probably we'll look at endothelial cell count and at pachymetry to begin with. If the cornea is not swollen and the cornea is clear, we will do a very careful cataract operation, just using Visco to protect the endothelium. We'll probably refer him to laser cataract rather than just phaco. And during surgery, you have to be very careful not to harm the endothelium, minimize phaco time. This is for the cataract operation. And just following him carefully afterwards, seeing if the cornea clarifies and he gets a reasonable vision, this is great, so we can follow him for the next couple of years. And if not, if he develops corneal edema and corneal decompensation, we will refer him to DMEC probably.
And what kind of lens target refraction would you suggest for these patients?
So just, emetropia. If planning on DMEC, because DMEC is actually refractive neutral, that was mentioned. So I'll go for -1/4 or something like this, -half, but no more than that.
Thank you.